Hi, good afternoon, everyone. I am Kinuko Mitani from Tokyo Medical University in Japan, and I'm taking a chair in the following two sessions entitled A Clinical War Risk MDS with Professor Eva Hellström-Lindberg. It is a great honor for me to sit here with Eva. I will take a chair in the first session and Eva in the second session. The first speaker is Eva herself. And the title of her talk today is Overview of the Treatment for Low-Risk MDS. Eva, please.
Thank you. Thank you, Seishi, Moshe, and Yasushi for inviting me to Kyoto. It's wonderful to be back. I will sort of give you an overview of the treatment for lower risk MDS. Now, how do I move them forward? Perhaps like this? No? Yes, I have nothing to disclose. And I have to start with something ancient, since you seem to like this. And that, no, I think you didn't change to the new topic. Anyway, I will take it then without slides. So, we are talking about no disease and CHIP and CCUS and MDS, and we are very proud of that sort of line of development. So we had that already 40 years ago when some of us were active. And then it was no MDS, not quite MDS, not yet MDS, and MDS. So you can think about that. There were ways before too. Anyway, talking about lower risk MDS, I think the first difficult question is, what is lower MDS really? Are we moving towards a risk-based or a taxonomy-based treatment? I think this is also a very important question. And I will then just touch upon the various treatment options for what we now, however we define lower risk MDS. So the work by Elsa and Eli Papa-Emanuel have given us the IPSS-MOL risk certification system, and it's amazing how quickly this actually became the tool to use in MDS. And we have then 6 categories, and they are separate in survival, and they do, with regard to AML transformation and overall survival, they really help us to guide our patients or to inform them perhaps. But if you look at the survival curves, and then you take one patient with moderate low MDS, the blue curve, and he is 59, he has a SORROW of 0. Is he happy with the projected median survival of 4 years? I don't know how many of you who are around 59 in this group would be super happy with that prognosis. On the other hand, you may have a moderate high patient, 72, a bit towards the limit of allotransplantation with some comorbidities. That is another patient. And these patients may also have different approaches to life and approaches to what they would like to risk or not. So we have actually to make prognosis more exact. We have to weigh the risk against expectations, and expectations differ from each individual. Some are willing to take enormous risk short time to being able to survive eternally or in the long run. And some others will say, no, I will not risk anything for the next 2-3 years because I have this and this and that to do. And we have to learn how to use time-dependent risk estimation, because this is what we do in the clinic. We sit there with the patient, we see the patient in 6 months or 3 months or something like that, and we say, this doesn't feel good. But we have no systems for that. So I would like to mention a few words about anemia, which of course you know is the most prevalent cytopenia of MDS. And there have been many, many curves looking like that. From diagnosis, if you divide patients into those that at diagnosis are transfusion dependent, approximately 50%, at least in the Swedish national registers, and those who are not. Those with transfusion dependency fare much worse than those that are transfusion independent. And there are many, many confirmatory studies on this. So why is then chronic transfusion need associated with reduced survival? Is it because it's not good walking around with a low hemoglobin level, 8 or 9 or whatever? Is it the effect of iron overload? Probably not only because the curves tend to separate up front. Or is it so that being anemic reflects a worse MDS biology? And it's probably some kind of combination of these three. But Maria Trudeau at our department, she asked the research question, is transfusion dependency at diagnosis and after primary treatment an independent risk factor? And we had then the advantage of having a large cohort of patients in Sweden being part of the IPSS-MOL study. So they were perfectly sequenced, they were quality controlled. And then we had the Swedish transfusion register, and no one can get any blood unit whatsoever anywhere in Sweden without it ending up in this register. So we decided, we asked the question when, and if you look at this diagram here, you see that C is then censored patients, either by death, transplantation, or leukemic transformation. And we wanted to have a time when as few patients as possible actually were censored. So we said, well, if we look at the time between 4 and 8, if patients are transfusion independent during these 4 months, 16 weeks, is that a prognostic? We also did that for 1 year and for 4 months. But we also thought that between 4 and 8 months, you very often see a response to azacitidine, if that has been achieved, and you see a response to erythropoietin-stimulating agents, if that has been given. And these are the two most frequent treatments we have. And when we looked then at transfusion independency during this 4 months interval, we actually indeed saw that it added to the IPSS-MOL. You have the IPSS-MOL score here, no difference depending on gender, age. TMDS, as always, shifts everything upwards. And transfusion dependency at 8 months, that is then between 4 and 8 months, actually is an independent risk factor. And when we made a model 1 being the IPSS-MOL, and model 2 being IPSS-MOL plus transfusion dependency at 8 months, we actually saw a significant difference in the added model, and this is now in review. Moreover, we looked at patients, divided them by the IPSS-MOL, the blue curves being IPSS-MOL very low to moderate low, and the purple curves being moderate high to very high. And the interesting thing is not what you see here. If you divide the higher risk patients into those that actually achieve transfusion independence, of course, this is still a high-risk disease with a median survival of 2.5 years, but there is a difference, and it may be useful for an elderly patient just on the border of transplantation to see that, yeah, it's not that bad if you respond to primary treatment with azacitidine. But on the other hand, if you have a lower risk disease and do not respond to any of the treatment given within the first 8 months, you actually have a survival curve that is very, very similar to higher risk disease being transfusion independent. And here you come to a sort of predictive survival or prognostic survival that is perhaps not so attractive. So one lesson in this is that perhaps if you do not respond with regard to transfusion independence, that is a reason to start talking transplantation with this patient. Interestingly, when we took the best group, the SF3B1 and the TP53, adding on the transfusion independence also separates the curves, perhaps less important, but anyway. So this is how I see we will go with the classification. This is what Elsa talked about this morning, and here we are talking about biological differences between different subgroups. And we know now that we have specific treatments for certain taxonomy subgroups, like the SF3B1, like DEL5Q, for example. And my hope is that we will slowly get around to learn each of these biological subgroups and find treatments that sort of more specifically target their baseline disease biology. So let's see, and we are not there yet. Okay, I would like to have a few words about the international MDS guidelines. This work in progress, I have no data to show you. The goal then is to increase the median and minimal level for management of patients with MDS. It's not intended for MDS centers with very high rate doctors, but it's written to really make it better for patients in general. It's developed under the auspices of the MDS Foundation, MDS Europe, there is a European system that I will not talk about, the ELN and the Harmony and others. And this time we have gone through all the literature that we want to write about, and everything will then have an evidence grade and a recommendation level. It's based on published literature and international document like the WHO classification. Some recommendations, of course, are based on clinical routine, consensus. We don't have studies on how to perform transfusion therapy, for example. And the final system will also have links to all existing national regional MDS guidelines. It's open sourced, web-based, anyone can enter without password and without any particular fancy platform. It should work from everywhere in the world. And after launch, it will then be managed and annually updated by an editorial board. And the persons who are working with this is then from the US, from Canada, from Europe, but also from some other parts in the world. And you can see the people here, and it's in 5 different groups. I must say that this group has really done a very good job. I think we will be ready by summer. And Robin Rashmi has made a fantastic job around the classification issue. So we have a variable driven classification tool now that Rashmi has developed, and you just click in the variables, and then you can click on the ICC button if you like that, or you can click on the WHO button if you like that better. And when they come, new classifications, as we know, will come, you can probably put that in the system too. So, how do we treat lower risk MDS? That was the background. Well, we have some patients that we don't treat at all. We watch and wait. They control frequencies, of course, depending on if this is a potential future stem cell transplant candidate or not. Most patients actually do develop cytopenia, and the vast majority of them develop anemia. And erythropoietin-stimulating agents is the first-line treatment for these. Perhaps if you have very high serum EPO levels, you can think otherwise. If you don't respond to ESAs, and if you have a hypocellular MDS, immune suppressive treatment may be an option for a very, very tiny, small portion of patients. If you have cytopenia, we can provide transfusions, thrombomimetics. They have never really been sort of proven in a controlled trial. Supportive care. If you have a ring sideroblast, SF3B1 mutation and transfusion dependency, we have the luspatercept. Luspatercept is also in the US, approved for other types of low-risk MDS, and we have the lenalidomide. I will not now talk about high-risk disease because that will be dealt with tomorrow. We should continue to test new approaches in clinical trials, new drugs, new compounds, new immunotherapies, new ways of dealing with our patients. And we always, also in the low-risk MDS, have to do the risk-benefit evaluation for hematopoietic stem cell transplantation. And I think then that time-dependent factors need to be taken into account. Okay, so now one slide about each, and we will hear more about the details later. So supportive care is mainly consensus-based recommendations. RBC transfusion should be based on symptom and function. Some patients do well with the hemoglobin of 8. Some need above 10 to be able to do anything, like picking up grandkids and so forth. We are very fond in Sweden at least of giving these on regular schedules. So if a patient is permanently transfusion dependent, we bring them in exactly every 14 days. We have the day before taking the tests to make it possible. And we try to transfuse them as close to patient's home as possible on these home care units. Chelation in patients with an expected survival counting in years. I think we have 3 drugs, the deferasirox, the deferoxamine, the ferriprone, perhaps a bit more cumbersome to use. I think we use a lot of deferasirox, but also a lot of deferoxamine. We are very fond of the porter kits in the Nordic countries, and it's very convenient to bring the patient in for transfusion, add on the pump with deferoxamine, take it away in 5 days, and then that 2 weeks chelation is actually done with. So if you like the pump, some patients take the pump wintertime when they have more clothes, and then when the summer comes, they take Exed for a couple of months. Platelet transfusions is not really regular in case of bleedings, of course. Thrombomimetic drugs, as I said, not really proven in any study, but of course you give it also to go from transfusion dependency to no bleeding. Platelets around 15 is also a gain for a patient. And then, of course, good management, contact nurses, dentists, infection control, vaccinations, and so forth. So all this is very important for patients. Erythropoiesis stimulating agents. It's possible, and that has been shown in many studies now, start before the onset of a transfusion need. The starting dose varies in studies. I would say between 10 and 30,000 units per week, depending on the patient weight, renal function, and severity of disease. If you have a tiny little lady with a bit sort of tricky kidney function, I would start very low. The only risk with ESAs is actually overdose, because if you go from 8 to 17 in hemoglobin over a month, that could really kill a patient. Maximum dose usually 60, but some centers go up to 80,000 per week. And response can usually be evaluated within 4 months if you sort of take up the dose in good time. Addition of GCSF has also been shown in many studies can be effective if no, but also in lost response, and in particular in SF3B1 mutated patients. So the response duration varies in studies, depends on what patients you put in. But I would say today, if you start before a permanent transfusion need, around 3 years, and we all have patients responding for more than 10 years. Loss of response, and this is important, is usually not associated with disease progression. Very rarely you see new mutations coming up. But what we have seen and also published in SF3B1 mutated disease, that the clone expands at the HCC level. At a certain point, the patients had no wild-type HCCs left, and then you don't really get EPO to work. So what we have shown we published before that if you start ESA before transfusions, you actually significantly prolong the transfusion-free time. But what we also have shown in a study, and these are preliminary data, is that if you are exposed to ESAs, in Europe it's very different. In some countries you can't give it, in some you can only give it in case of transfusions, and in some you can give it when you think the patient needs it. But it really, being then exposed to ESA prolongs survival fairly significantly, as you see here. And this is then a propensity score matched analysis taking social economics factors and things like that into account. Then we asked the question, is it so that if you start after some transfusions, is that not worth anything? But then we see that that is the case. So the yellow curve is actually patients who have received 1 or 2 or 3 or 4 transfusions before the start. And even if that is not as good as being non-transfusion dependent before start, you can actually benefit at least during the first 3 to 4 years from this. So start early, but don't give up if the patient has some transfusions. Lenalidomide then, being then the first actually clonally active low-risk drug that we got. The indication is low-risk MDS with isolated del5q. perhaps including trisomy 8, and transfusion need, refractory or ineligible to erythropoietin, and no TP53 mutation by NGS sequencing. We could also earlier do it by HC, but now, MDS is probably what we use. This is the MDS-004 study published by the group led by Pierre Fontenay in 2011. This is then recalculated by IHC, less than 1 or more than 1%. And you can see the survival curves in patients without TP53 mutation and with even these very, very tiny signs of P53 mutation, and in particular a very marked difference in leukemic transformation rate. I think this study is another study published by Sperling some years ago. Also, Bed Ebert has been involved in this study, and they looked at a large cohort of patients with therapy-related myeloid neoplasias, and they saw that the use of lenalidomide actually could promote TP53 mutated myeloid neoplasm. They also made an accompanying mouse studies with chimera, wild type, and TP53 mice, and they could see that exposed to lenalidomide and pomalidomide, which is then a cousin drug, there was actually a positive selection of the TP53 clones. And what the conclusion was that when you give lenalidomide to P53, wild type, normal hematopoietic stem cells, nothing happens. You result in apoptosis. Interestingly, when you give lenalidomide to myeloma cells, you work to the Icarus system and you lead to apoptosis. But if you give lenalidomide to TP53 mutant HCCs, it works through casein kinase, and that leads to survival. They also speculate in this paper that they could actually promote or actually cause TP53 mutations. That is probably a bit more difficult to prove, but selection definitely. It's therefore, I think, this study that is only in abstract form presented at the EHA 2023 and done by a very talented young Italian hematologist, Elena Crisa. She wanted to do a prospective stop study on lenalidomide, but that was in the end not feasible. So what she did in multi-center collaboration was that she found 118 patients who by various reasons had stopped lenalidomide at some point in their treatment. And then she looked at the overall duration of transfusion independence, and all these patients were then they had stopped in remission of some sort, in erythroid remission and transfusion independence. And even if this curve slopes down, you can look at the 50%. When 50% have lost their transfusion independence, that amounts to more than 4 years, only 5 years. I think this is very important. And then she divided the curve into those who had received more than 12 cycles and those that had received less than 12 cycles. The majority of these ones had actually got side effects of various sorts. But even in this group, you end up at almost 3 years of transfusion independence. And knowing that tiny, tiny P53 clones are common in the L5Q MDS, let's see what this leads us to, but I think the data are very, very intriguing, and for my sake, if patients complain about side effects, I'm very positive in allowing them a stop in treatment. Then you can reassume it when they relapse. So luspatercept, we will hear more about that from Ove Platzbecker in a while. It has an EMA and FDA license for MDSRS by FDA also, I think, for transfusion-dependent anemia in general. There will be several studies. There's the medalist study, the 2-to-1 randomized study on patients with MDSRS, the treatment group 38% transfusion independence up to 24 weeks, for 8 weeks, and then 28% for more than 12 weeks. Response rate higher in low transfusion burden and those with a high transfusion burden, and clearly better response in those with a very, very moderate transfusion burden. Interestingly then, there is no reduction of allele frequency of mutated cells. So it doesn't really work by reducing the clone in any way. The availability in Europe is relatively low. In countries with a governmentally financed drug, it's very low, including Sweden, while I think in countries where you have insurance company-based sort of access to drugs, it's a bit higher. So I had some questions to Ove, but he's not here and probably doesn't listen to this, but my two questions were, does luspatercept primarily act on SFTB1 mutated or wild-type cells? We know that it was done in an osteoporosis trial, and it was stopped because patients got very high blood levels. And has it yet become a doping agent? That would be interesting to hear. Okay, immunosuppressive agents then. What we say in the guidelines is that younger patients with hyper or normoplastic MDS and no cytogenetic genetic abnormalities except trisomy 8 could be eligible. They are usually young patients. And there are very few modern studies in the NGS germline mutation era, so we don't really know. The drugs we use are the ones that we give to aplastic anemia, ATG followed by cyclosporin A, L-trombopag. In elderly patients, we skip the ATG and go for cyclosporin A and L-trombopag. There is a recent publication, at least some years ago, then in 2020, of 570 patients with a low median age and low IPSS scores, but very low CR and RBC-TI rates. They were only 12.5% and 33% respectively, and a fairly high progression rate to AML. But I think it would be super interesting to take this cohort, clean up what we now know on germline, clean up the GATA1s, the SAMD9L, all the telomerase mutations, ERC, C6L2, and then see the response rates in those where we are positively sure have no germline. That perhaps would lead to better response rates. Imetelstat is recently published by Platzbecker, and there is also earlier phase 2 studies. The phase 2 study showed then response rates of 37% and 23% respectively, 8 and 24 weeks, with a fairly long TR duration, which is interesting. The 2-to-1 phase 3 trial reported 40% 8 weeks for the study drug versus 50% for placebo. This is a cytotoxic drug, so the most common side effects were neutropenia and cytopenia. But the interesting thing here is that here we have a new lenalidomide lookalike. So we have significant VEF reductions in these 4 genes that actually were measured. And if this can be confirmed in prospective trials, this will be the second agent for lower risk MDS with a potential tumor inhibiting effect. So, to summarize then, treatment of myelodysplastic syndromes, in this case lower risk MDS, we have to look at the patient. What kind of patient it is? What is the preferences, the age, the frailty index, and all these things. And we have to make a very thorough clinical assessment. Ask questions about diagnosis, prognosis, but also about taxonomy, about germline conditions. And we have to really define this kind of patient. I hope that we will go towards taxonomy-based treatment in the future. And then we have to ask the question for each patient, even for low-risk patients, should we try to cure the disease? Because today the only way to do this is hematopoietic stem cell transplantation. Or are we doing our best with the patient bone marrow as it is? And we go for non-curative treatments, aiming to prolong survival. I do agree with Guillermo that, but also, of course, prolong quality of life. But in my way and in my experience, improved quality of life very often leads to prolonged survival. And we have to be very humble that we don't know yet very much. So these are my acknowledgements, and thank you very much. Happy for questions.
Thank you very much for your beautiful overview of the treatment for low-risk MDS. You have emphasized that transfusion status at 8 months is important to predict prognosis. And further, you introduced international MDS guideline under progress. Thank you very much. Oh, please.
Thank you, Dr. Lindberg, for always teaching us. And I have to say that I never understood that figure of the transfusion dependency and impact on survival until later on. But I have a question for you. And there's no answer, but maybe a provocative question. So we heard in the morning a lot about these new molecular classifications, etc. And I think actually, if I learned something from that IPSSM, is this phenomenon that I think Dr. Komrocki refers to as upstaging, right? You have lower risk disease, now you're intermediate or high. If you look at the American Society of Stem Cell Transplantation, there is actually not even a mention for transplant in lower risk disease, and they just published like last year or something like that. So now you are in Stockholm, and you see someone with prototypical low-risk features. But now this person, and we see these patients all the time, actually has 5, 6, 7 mutations, whatever, with significant BAFs. And now the IPSSM is telling you, actually, this is actually higher than what the IPSSR or the all IPSSS shows. Will you transplant that patient if he or she was a candidate for transplantation, meaning as a donor, et cetera, et cetera? Yeah. Should we start switching the paradigm based on the molecular data?
This is a very good question, and I can say, I mean, you probably have these patients too. So sometimes you have a patient. I have some patients. I'm thinking about one. He has 5 mutations. I mean, fairly bad ones, including a RUNX1 and so forth. Not P53, but I mean the other bad guys and many. But he has perfectly normal blood levels. I mean, it's nothing. It's not even cytopenic, or rather not cytopenic. So then you really have to discuss with this patient. Then you have to ask, you have to inform the patient. Of course, his risk is probably, because that's so unusual, having normal blood values and really bad genetics. So it probably doesn't really fall out, even not in the IPSS model. That is a discussion. It's, of course, some that I will follow very carefully. And if something happens, I would probably shift. Or if the patient says, I would like to have this done with, I would go with that. But I do agree, you have to, I think cytopenias are also important in various ways.
Thank you.
Okay, the last question, please.
Yeah, sure. Great. Okay, Eva. So just following on the theme of like what the regulators should look for to approve a drug in lower risk MDS, and you know the pushback yesterday against transfusion independence as an endpoint was just amazing to me, because the argument is that we know that transfusion dependency and anemia has been correlated with worse survival, but improvement of anemia and transfusion dependence has not been shown in any prospective trial to associate with overall survival. And is 8-week or 16-week even is enough going forward to approve a drug in lower risk MDS when we don't have quality of life improvement again in any study? And I think the regulators are going to probably become more stringent at approving drugs with these endpoints. So how do you think we should handle what makes, I think all of us agree that transfusion dependence is important, but it seems tough to communicate that to non-MDS kind of groups.
So my comment is that I think that the problem is that in lower risk MDS, studies are not long enough to prove improved survival. I mean, they're cut after 6 months, if you are lucky after 12 months, and you don't really see the endpoints like survival. I mean, this study that I just briefly mentioned, it also includes a fairly advanced Markov model where we look at transitions. And we could actually show that if you change from being transfusion dependent to transfusion independent, your outcome is actually proven. But these patients we have super long follow-up data on because they are. So I think that transfusion independence is important for survival, but I agree that very few trials follow the patients long enough to be able to prove it, and they're not designed for it. So that would be my comment.
Okay, the very last question, please.
Thank you, Eva, for excellent talk, as well as raising several important thoughts. Just one comment that I will have mainly to Guillermo but to all of us. I think there is another endpoint which we should not forget, and this is quality of life. If we ask our patients, quality of life matters to them not less than survival. So we all have to take it into consideration. And my question regarding to that, I would like to go back to the beginning of the treatment. What is your hemoglobin threshold for transfusions? I mean, it's always, you know, like when the patient is symptomatic, well, the patient is always symptomatic when the hemoglobin is 8 or 8.5 or even 9, always symptomatic. I've never met a patient who would tell me that I feel well. No, they always feel bad. But all the restrictions, and there was also a nice series of blood transfusions in New England about that, not only about MDS patients, but in general. And the whole atmosphere of the world today is being more and more restrictive. And in the hospital, you know, they send you the restriction, 9, no, 8.5, no, 8, think to, what is your hemoglobin threshold considering the quality of life?
Okay. So, two ways. One is when you start to become transfusion independent, because then you need to understand the patient. But once you have come into this 2 units per 2 weeks or per 3 weeks, I mean, many patients come there, then we let the patient set the threshold. And then we also change from threshold to target. And this is very important. So we say to these units that transfuse patients, this patient has a hemoglobin target of 10. Meaning that the patient should be above 10 all the time or most of the time. And then you actually make sure that you transfuse them a bit sort of preemptive. So this is at 10, I would say. Some patients, if they're super sick heart-wise, they could have 110. Some are happy with 8.5 or 9. But the patient has to tell me what level of hemoglobin do I need to perform, to do the things I would like to go to the bank, pick up my grandkids and so forth. And knowing from thalassemia transfusion that if you are very anemic, you also take up more iron from the bowel. So once you are there, it doesn't give you more iron overload to be transfused. It's just that you are, instead of circling on a constantly low quality of life, you circle up here, and you're not transfused more often. We have actually showed that in a study many years ago and published it. So it's the going up. But so this. Are you happy with that response? Why only partially? Yeah.
Okay, thank you very much for your Eva and the audience. So let's move on to the next talk. The next speaker is Dr. Michaela Fontenay from France. She's talking about SF3B1.
So thank you very much, Dr. Ogawa, Dr. Miyazaki, and also to the MDS Foundation Committee for inviting me. So today I will talk about myelodysplastic syndrome with SF3B1 gene mutation. Just a few words about pre-mRNA splicing. This is the way the mRNA will mature, and this starts by the recognition of the intron sequence by the U2 and the U1 complex, the U2 being at the 3' splice site. And this is a crucial step before the cycle is completed by 2 transesterification catalytic steps leading to the intron lariat release. And we will focus on the U2 complex first. Sorry. This complex is essentially made of 15 different molecules, and SF3B1 is part of them and is involved in the recognition of the branching point. And together with the U2EF complex, it makes the recognition of the AG3' splice site. SRSF2 is also a serine arginine factor described to be mutated by the primary paper by Professor Ogawa. This factor is involved in either enhancing or silencing splicing depending on the exonic sequence it binds to. So these factors are mutated in MDS with high frequency, and it is recognized a phenotypic heterogeneity of MDS with splicing factor mutation. On one hand, we have SF3B1 mutated MDS with anemia, erythroid dysplasia, low blast, when few commutations and a relatively good prognosis. And on the other hand, we have the SRSF2 U2EF1 mutated MDS, which are mainly characterized by thrombocytopenia, neutropenia, and excess of blasts with a high risk of AML evolution, meaning that this different splicing factor mutation leads to distinct hematopoietic cell specification and also to a distinct propensity to genomic instability. Some splicing events are specific to each type of mutation, so maybe they are responsible for at least part of this distinct cell specification. In this bulk RNA-seq of 189 low-risk MDS, we can see here on the bar plot that there is a really distinct splicing events with SF3B1 having alternative 3' splice site use quite frequently, and also the intron retention reduction that is characteristic of SF3B1, while in SRSF2 or U2EF1 mutant, there is much cassette exon, sometimes the inclusion of weak exon or exon skipping. So if we wanted to consider the alteration of cell specification by SF3B1 mutation, we expanded the erythroblasts from the bone marrow of patient having SF3B1 mutated MDS in comparison to control and also to splicing factor wild-type MDS. And we perform global proteomic and also RNA sequencing. And this graph on the bottom showed you that indeed, even in a culture condition, we are able to see that the differentiation is hard to reach when SF3B1 is mutated, but also in other MDS conditions. So this graph is quite busy, but this ingenuity pathway analysis show you that there is indeed a lot of differences between SF3B1 mutant erythroblasts compared to the control ones. And in particular, we observe that M biosynthesis is altered and also iron homeostasis, and a lot of terms are related to control of replication and DNA damage response or checkpoint control, both at the basophilic stages or polychromatophilic stage, or both. So we and others have demonstrated that part of this modification of the proteome are indeed related to the use of 3' alternative splice sites. And we demonstrated, for instance, that the erythropoietin gene was modified by the addition of 12 nucleotides between exon 2 and 3, and this led to the translation of a protein that is a neoprotein with 4 additional amino acids. This protein retains the normal function of erythropoietin, which is a repression of hepcidin, leading to systemic hyperferritinemia. There is also other example of such use of 3' alternative splice site, like ABCB7 that has been shown to be related to mitochondrial iron overload, or PPOX gene, which is related to a lower level of heme biosynthesis per cell. So there is an important feature of erythropoiesis or granulopoiesis, which is a selective increase in intron retention during the differentiation, and this modifies the transcript function or stability to define the cell identity. And what is really important in SF3B1 mutant cells, and we saw that also at erythroblast level, is the very high frequency of reduction of intron retention at basophilic stage and increasingly at polychromatophilic stages. So we looked at the gene ontology term associated with the gene affected by such a reduction of intron retention, and these genes were indeed involved in the DNA damage response, the control of the cell cycle, and also the regulation of histone deacetylation, quite surprisingly for us. So the second function of a splicing factor is, has been shown to be the maintenance of genomic instability. Several papers have deciphered this function of splicing factors, in particular the Jim Manley paper appearing in Cell in 2005. And in this last one, published in 2018, it has been suggesting that splicing factor mutation could lead to an augmentation of R loops, meaning that the genomic instability of this disease could be related to the formation of R loops. So, what are R loops? R loops are formation in the DNA made by the hybridization of the transcribed RNA with a single arm of DNA, and the structure is also composed of the displaced single DNA strand. And when SRSF2 or U2EF1 are mutated, it has been shown that these two factors prevent the release of RNA pol II posing when the transcription is initiated, and this occurs roughly at 50 base pair from the transcription start site. And this generation of R loop at promoters is able to induce a replication stress, making a risk of DNA damage increasing. So we wonder during this work why SF3B1 MDS has less propensity to DNA damage and to genomic instability. So we ask the following question: do all splicing factor mutants cause the same R loop patterns? What is the relationship between R loop profiles and splicing events? What are the consequences on replication and cell differentiation? And the final question was, can we rescue this phenotype? So to answer this question, again, we derive from CD34 positive bone marrow progenitors, the erythroblasts in culture, from control cells, but also SF3B1 mutant samples and SF3B1 wild-type MDS samples, and we took the cells at the stage of basophilic erythroblast to isolate the DNA and perform the drip sequencing experiments, which is quite challenging on primary cells. And for that, we use one antibody, S9.6, which is specific of R loop, meaning the hybrid between RNA and the DNA. And then the DNA is cut by a restriction enzyme before undergoing the immunoprecipitation. So at the end, we obtain a fragment of DNA, and after that, we have the bioinformatic analysis enabling us to reconstitute the sequence. So this is at the bottom an example of what we observe. This is a region of chromosome 7 showing that the level of and number of R loop in SF3B1 mutant samples is lower than the SF3B1 wild-type samples and control samples. Here I show you the control with RNase H1. RNase H1 is removing R loop by digestion of the RNA strand. And this is here the integration of our results on several samples. We have plotted here the number of peaks which were shared by each samples of one group. So you can see easily that there is a much important decrease of R-loop in SF3B1 mutant samples compared to this SF3B1 wild-type sample containing SRSF2 mutant and U2EF1 also. So where are the lost R-loop? We found them essentially at promoters and transcription start site and also in the gene bodies. You can see here that there is no more R-loop visible in the 5' UTR, less at the promoters and TSS, and also less at the gene body. Meaning that first, our technique enables us to identify the R-loops at promoters and also at gene bodies, which are quite different R-loops. We can discuss this later. So here I show you an example of what we observe in the SF3B1 mutant samples in the close vicinity of the promoter of that SUS12 gene. And you can see here that there is a very important decrease of R-loop in this promoter regions. So because R-loop are regulating the transcription and the level of expression of mRNA, we integrated the DRIP-seq and RNA-seq data of the same sample on erythroblast, and we found that when the R-loop was absent at the transcription start site and promoter regions of the SF3B1 mutant samples, the expression of the mRNA was decreased. This is represented here by the difference between wild type and mutant. And this was very significant, making the link between the R-loop formation and the activity of RNA pol2. So some papers, and in particular these papers from our collaborator Benoît Palancade in Institut Jacques Monod in Paris, demonstrated that intron excision was a way to protect the genome from the formation of R-loops, because it reduces the the congruence between the mRNA and the DNA templates. So what these papers show also is the fact that the binding of the spliceosome to the genome was indeed preventing the formation of R-loop, suggesting a specific role of splicing factor in that function. So we integrated again the results of DRIP-seq and RNA-seq data, and I show you here the example of the COSY gene with the intronic sequence here and the reduction of intron retention in the mutant condition associated with a lower level of R-loop on the mutant samples here. And when we perform this Venn diagram, we observe that 70% of the reduced intron retention we observe in the RNA-seq data was in fact overlapping with a lost R-loop. So at least the reduction of intron retention was participating in the loss of R-loop in the samples. So the next question was what are the consequences on replication and cell differentiation, and can we rescue the phenotype, if any? So R-loops are obstacle to replication in two ways. If the replication and the transcription are co-directional, there may be a collision if the helicase is going too fast, I would say, meeting the R-loop formed by the pausing of RNA pol2. And to resolve that, what happened is the release of pol2 and the arrest of transcription. On the contrary, when the collision is head-on, the way the genome is solving this problem is the collapse of the fork. So in our condition of SF3B1 mutant sample, conversely, the loss of R-loops may suppress the collisions and facilitate replication. So to look at that, we perform a BRDU assay to look at the incorporation of BRDU in the genome during S phase, and we observe that indeed the relative fluorescence intensity, meaning the intensity of incorporation was increased in samples with SF3B1 mutation compared to the other situation, and also the percentage of cells in S phase. And to confirm that there is an increase of DNA synthesis, we perform DNA combing on primary samples, and we compare the different situations. This is a technique in which there is 2 pairs of nucleoside analogues for a given time that allow to measure the distance of incorporation and finally to calculate the fork speed and to look also at the fork symmetry. And what we observe is the fact that the fork speed was increased in SF3B1 mutant samples very significantly, but the fork symmetry remained as in control cells, meaning that there is not much obstacles to the progression of the fork in the 2 directions. So what are the consequences on the DNA damage response? So we were comparing by using 4 different labeling the situation of SF3B1 mutant samples, erythroblasts, auras, SRSF2, U2EF1, and splicing factor Y-type samples. And we use hydroxyurea to make a positive control of normal cells. And what was very evident here is the fact that SF3B1 mutant cells have only labeling with RPA 32, which is the labeling of single-strong gaps. And we didn't observe any labeling of double-strong break. Like what we observe in SRSF2 or U2EF1 samples with this gamma H2X labeling or 53BP1 labeling. So we conclude from these experiments that the SF3B1 mutant erythroblasts endure a chronic DNA replication stress made of accelerated fork speed and single-strong DNA exposure, which evocate fork uncoupling by the uncoupling of the activity of the helicase that unwinds the double-strong DNA helix and the progression of the polymerase, making large stretch of single-strong DNA which are immediately covered by RPA protein to protect them from a double-strong break. So to definitely assess the relationship between the loss of R loop and the replication stress we observe with increased fork speed, we took advantage of this publication of the team of Aguilera, showing that the Tau complex and associated with a SYNC3A histone deacetylase complex were involved in the resolution of R loop, meaning that if we use pan-HDAC inhibitors, we can rescue the formation of R loop. So this is what we did, and we go back to the DRIP-seq experiment in samples treated with HDAC inhibitors, and you can see here that in SF3B1 mutant samples, the new 3-1 here, we obtained the rescue of R loop formation for 2 of them. We also increase a little the number of R loop in control samples, while surprisingly we decrease completely the number of R loop in SF3B1 Y-type samples. And the rescued R loop were mainly located in the gene bodies. So what was the consequence on gene expression? So we have some examples that we can observe the increase of R loop with HDAC inhibitors in the vicinity of some gene promoters like BCL2L1, and we observe here by RT-qPCR that indeed the expression of the gene was increased in SF3B1 mutant samples. And this was obtained without any modification of the splicing pattern of some genes which had reduced intron retention. So finally, we found that HDAC inhibitor was able to slow down the fork progression with here the decrease of the speed in SF3B1 mutant samples treated by HDAC inhibitor, and we also decrease the percentage of S-phase cells. And finally, we obtain a rescue of differentiation with here the increase by flow cytometry of the percentage of the GPA positive CD49D low cells, representing the more mature erythroblasts in our culture. And you can see here nice differentiating cells in the presence of HDAC inhibitor. So finally, and to summarize, I showed you that SF3B1 mutated erythroblasts have a depleted R-loop landscape compared to control and to SRSF2 due to AF1 mutated erythroblast, at least partially related to intron retention reduction, a specific splicing event driven by SF3B1 mutation. Also, SF3B1 mutated erythroblast endure a chronic replicative stress with accelerated fork speed and single-strand DNA gaps. And rescuing R-loop formation by inhibiting histone deacetylase activity improves the erythroid differentiation. So this work is currently in press. And I would like to thank all my team and the collaborators to this work, especially Marc-Henri Stern at Institut Curie, Frédéric Chédin in UC Davis, California, Benoît Palancade in Institut Jacques Monod, Angelos Constantinou, who inspired this work at the very beginning, and our funding sources, of course, the Groupe Francophone des Myelodysplasies and the patient, and I thank you for your attention.
Thank you, Michaela. Thank you, Michaela. We already have a question. Okay. Please.
Thank you. This is really fantastic presentation. So it's actually incredible to see the connection with these other epigenetic regulators. You know, as you know, we developed these HDAC inhibitors maybe 15, 16 years ago, and they never really worked out. There were some studies in low-risk disease that didn't really work, but in those days we didn't know about SF3B1 mutation. So my question is this through differentiation, or there is also some cytotoxic effect? Were you able to measure this? Because these drugs can actually induce apoptosis.
Yeah, sure. So we measure apoptosis, and we had no increase of apoptosis during treatment in the condition we use, of course.
Do you know more or less what type of concentration of the borinostat and have you used? And is this something that you have also mimic with other HDAC inhibitors, or just with the borinostat?
Thank you.
No, that was a question.
I'm sorry?
Eva?
So the question is, what kind of concentration of the HDAC inhibitor have you used, and have you seen the same low dose?
Low dose, yes. I don't know, I'm not quite completely aware of the concentration in human when it was used for high-risk MDS. But I know that we compare to other studies using HDAC inhibitors on cell line and cancer cell line. And we had to lower the dose to obtain the differentiating effect compared to what people wanted to obtain, meaning the killing of cancer cells.
And very quickly before Dr. Ogawa, is this only with borinostat, or have you seen this with other drugs in this class?
We use only vorinostat, but in the work from Aguilera, they also use two different HDAC inhibitors.
So, Seshoga, fantastic talk. So I may have asked you before, but I'm a little bit confused. So there are two, the situation in retained in our group is very different between SSRB and other splicing mutations. But nevertheless, they, both these group of tumors have similar phenotype. Anyway, so my first question is, why so SSRB mutant cells have reduced retained intron? And this is the first question. And yes.
Thank you very much. So I think you know maybe more than I on that subject. So the question is is there an increased activity of the mutant SF3B1 compared to the wild type SF3B1. So this is the first thing, the first thought we have about that. For the moment, there is a paper in bioRxiv suggesting that it is not the case, but it is with omics studies and run-on or glow sequencing. And for me, it's not biochemistry, and I think the answer could come from biochemistry, looking at the affinity of mutant splicing factor for RNA or for chromatin. So for the moment, I don't know, because we didn't perform the experiment, but to my knowledge, there is no clear evidence in the literature.
So anyway, if the RO formation is, could be the target of some therapy, so the SSC muted cases and other splicing muted cases has a very different behavior, probably shows response to the very different behavior, right?
What do you
because
mean?
SSC mutation, so if the RNA loop retention is a target of the therapy, so this drug probably shows a different influence of the SSC mutated cases, other splicing factor mutated cases, because one side retained intern is reduced, and the other side is retained intern so increased. So this drug influence a different, cause a different.
Yes, I don't know why for the moment, but what is possible also is the fact that the R loop made in SRSF2 mutant, is also due to the posing of RNA pol 2 and the formation of R loop at promoters. But we know also that some splicing event may occur, and the inclusion of weak exon, could also induce the formation of R loop in SRSF2 or U2EF1 samples. So maybe this could influence the formation of R loop, not only at promoters, but also at gene bodies. And finally, if the HDAC inhibitor is doing something more at the gene body, we can imagine that there is something there more clearly at the gene bodies than in the promoters. So we have no answer to this question yet, but this is something we should look at.
Okay, thank you.
Thank you.
Okay, excuse me. We are so behind the schedule, so I'd like to close the session. Thank you very much.